What I'm about to reveal is going to shock you. That blood pressure number your doctor has been chasing for years, that perfect 120/80 everyone talks about, might be slowly killing you. And before you click away thinking this is just another clickbait health video, I need you to understand something. I'm Dr. Sandra Whitmore. I've been a cardiologist for 27 years, and I've seen what happens when we treat older adults like they're middle-aged. I've watched patients decline, watched them fall, watched them lose their independence, all because we followed guidelines that weren't designed for their aging bodies. Right now, at this very moment, there's a 73-year-old woman sitting in her doctor's office, being told her blood pressure of 138/82 is too high. She feels fine. She's active. She walks her dog every morning, but her doctor is adding a second medication because the guidelines say she needs to hit 120/80. And in 3 months, she's going to fall. She's going to break her hip. And her life as she knows it will be over. And simultaneously, somewhere else, there's an 80-year-old man whose blood pressure is being pushed down to 118/76. His doctor is celebrating. The numbers look perfect on paper, but this man can't think clearly anymore. He's confused. He's tired all the time. His brain isn't getting enough blood flow, and nobody's connecting the dots. I'm tired of watching this happen. I'm tired of seeing seniors suffer because we're following one-size-fits-all guidelines. And today, I'm going to tell you the truth about blood pressure targets for older adults. But I'm not going to give you the number yet, because if I tell you right now, you'll write it down and leave. And you need to understand why the number is different for you. You need to see what happens when blood pressure is too low in aging bodies. You need to know the science that your doctor probably hasn't read. Before I go any further, I need you to do something for me. Comment below with 3 things: your current age, your most recent blood pressure reading, and whether you've experienced dizziness when standing up. Just write it like this: 72, 145/88, yes, or 68, 128/76. No. I need to see what's happening out there. I need to understand what people are dealing with. This data matters. Your story matters. Let me tell you about Robert, because Robert's story is going to change everything you think you know about blood pressure management in older adults. Robert was 71 years old when his wife dragged him to my office. She was concerned. For the past 6 months, Robert had been slowing down, as she put it. He was tired all the time. He'd given up his Saturday morning golf games. He'd stopped going to his woodworking shop in the garage. He just sat in his recliner watching TV, barely engaged with life. His wife thought maybe he was depressed. Maybe he had early dementia. Something was wrong, and she wanted answers. I looked at Robert's chart. His primary care doctor had been managing his blood pressure for 5 years. 5 years ago, when Robert was 66, his blood pressure was 152/90. High. His doctor started him on one medication. The pressure came down to 138/84. Better, but not good enough, according to the guidelines. So they added a second medication, then a third. Over 5 years, Robert went from 1 blood pressure pill to 4, and his numbers looked beautiful on paper. 118/72. Perfect. His doctor was thrilled. Robert's wife, on the other hand, was watching her husband disappear. I asked Robert to stand up. He pushed himself out of the chair slowly, carefully. He stood there, swaying slightly, holding on to the exam table. I took his blood pressure sitting, 118/72. Then I took it standing, 88/58. A 30-point drop in systolic pressure, severe orthostatic hypotension. Robert, I said, when you stand up, do you feel dizzy? He nodded. Every time. I thought it was just getting older. Do you have trouble concentrating? Trouble remembering things? His wife jumped in. Yes, he can't follow conversations anymore. He forgets what we talked about 5 minutes ago. That's why I thought it was dementia. I explained what was happening. Robert's brain sits at the top of his body. Blood has to flow upward against gravity to reach it. At 71, Robert's arteries are stiffer than they were at 40. His baroreceptors, the sensors that detect blood pressure changes, respond more slowly. When Robert stands up, his blood pressure drops dramatically, and his brain doesn't get enough blood. Even when he's sitting, a blood pressure of 118/72 might not be providing adequate cerebral perfusion for his aging brain. The fatigue, the cognitive fog, the loss of interest in activities, all signs of insufficient blood flow to the brain. But his doctor said 120/80 is the goal. His wife protested. Isn't that healthy? For a 45-year-old, I said, yes. For a 71-year-old with stiff arteries and slow baroreceptors, no. Robert doesn't need lower blood pressure. He needs higher blood pressure. I reduced Robert's medications. We went from 4 pills down to 2. His blood pressure came up to 136/80, still below 140, but higher than where he'd been. 2 weeks later, Robert's wife called me. She was crying. "I have my husband back," she said. "He's playing golf again. He's talking to me again. He's himself again." Robert's cognition had returned. The fog had lifted. His energy was back, all because we stopped pushing his blood pressure too low. But here's what terrifies me about Robert's story, and this is what I need you to understand before we go any further. Robert was one of the lucky ones. I caught it. But how many seniors out there right now are living in that fog, that exhaustion, that cognitive decline, and nobody realizes it's their blood pressure medication? How many are being diagnosed with early dementia when really their brain is just starving for blood flow? How many are being put on antidepressants when really they just need their blood pressure to come up? Now, comment brain fog if you or someone you know has experienced confusion or memory problems that started after blood pressure medications were increased. I want to see how common this is. Before I tell you what your blood pressure should actually be, you need to understand something fundamental about how aging changes everything. You need to understand why 120/80 is not a magic number that applies to everyone at every age. Let me tell you about Dorothy, because Dorothy's story is going to reveal the second reason why blood pressure targets must be different for older adults. Dorothy was 79 years old, living independently in her own home. She was proud of her independence. She cooked her own meals, she did her own laundry, she managed her own medications. Her blood pressure had been running around 148/84 for years. Her doctor kept telling her they needed to get it lower. Finally, at age 78, Dorothy agreed to start medication. The medication worked. 3 months later, her blood pressure was 122/74. Her doctor was pleased. Dorothy felt okay, maybe a little tired, but she figured that was just age. Then one morning, Dorothy got up to use the bathroom. She stood up from her bed, took 3 steps, and felt the room spin. Her knees buckled. She fell, hitting her head on the corner of her nightstand. She lay there on the floor for 6 hours before her daughter found her. The fall caused a subdural hematoma, bleeding in her brain. She needed emergency surgery. She survived, but the recovery was brutal. 3 weeks in the hospital, 2 months in rehab. When she finally went home, she needed a walker. She needed help with bathing. She was terrified to walk alone. Her independence was gone, all from one fall, all because her blood pressure was too low when she stood up. Here's what was happening to Dorothy. And this is the second critical thing you need to understand. As you age, your body's ability to regulate blood pressure when you change positions becomes impaired. When you're young and you stand up, sensors in your blood vessels detect the pressure drop. They send signals to your brain. Your brain tells your heart to beat faster and tells your blood vessels to constrict. This happens in milliseconds. Your blood pressure stays stable. You don't feel dizzy. But in older adults, this system slows down. The sensors, called baroreceptors, become less sensitive. They detect the pressure change more slowly. They send weaker signals. Your heart doesn't respond as quickly. Your blood vessels don't constrict as fast. There's a delay. And during that delay, your blood pressure drops. Blood flow to your brain decreases. You feel dizzy. You lose your balance. You fall. This is called orthostatic hypotension, and it's one of the leading causes of falls in older adults. And here's the terrifying part. If your baseline blood pressure is already low, if medications have pushed it down to 120/70, when you stand up and it drops another 20 or 30 points, you're in the danger zone. You're at 90 or 100 systolic. That's not enough to perfuse your brain. You're going to fall. But if your baseline pressure is higher, say 140/80, when you stand up and it drops 20 points, you're at 120. Still adequate, still safe. The higher baseline protects you. Dorothy's doctor never checked her standing blood pressure. He just checked it sitting. The sitting pressure looked great, but the standing pressure was catastrophic, and nobody checked until it was too late. Now, before I show you the exact numbers you should be aiming for, before I tell you what your blood pressure target should be based on your age, I need you to understand the third piece of this puzzle. I need you to understand what the research actually shows. Not what your doctor thinks it shows, what it actually shows. There's a famous study called the SPRINT trial, Systolic Blood Pressure Intervention Trial. This study compared 2 blood pressure targets, less than 140 versus less than 120. The intensive group, targeting under 120, had fewer heart attacks and strokes. This study is why guidelines changed. This study is why doctors now push everyone toward 120 over 80. But here's what most doctors don't know about the SPRINT trial. They excluded a lot of people. They excluded anyone with diabetes. They excluded anyone with a history of stroke. They excluded anyone who was frail. They excluded anyone with dementia. They excluded anyone in a nursing home. In other words, they studied relatively healthy middle-aged and younger old adults and found that pushing blood pressure below 120 helped them. And then guidelines writers applied those results to everyone, including the exact people the study excluded. But there's newer research published in 2024 in the Journal of the American Medical Association. This study followed real-world older adults, people with diabetes, people with prior strokes, frail people, people over 80. And here's what they found. Among adults over 75, systolic blood pressure between 130 and 145 was associated with the lowest mortality. Lower than 120 was associated with increased falls, increased hospitalizations, increased cognitive decline, and increased death. Higher than a 150 was associated with increased cardiovascular events. But the sweet spot, the range where people lived longest and had the best quality of life, was a 130 to 145. Let that sink in. The number your doctor is calling too high might actually be the safest number for you. Now comment 130, 145 if you're over 70 and this is the first time you've heard this. Comment if your doctor has been telling you that anything over 130 is dangerous. I want to see how many people have been given outdated information. Let me tell you about James. Because James's story is going to show you what happens when we individualize blood pressure targets instead of following one-size-fits-all guidelines. James was 84 years old. He had diabetes. He'd had a mild stroke 5 years earlier. He lived in an assisted living facility. His blood pressure was 156 over 88, high. His doctor wanted to lower it, wanted to get him under 130, started him on medications. James came to see me for a second opinion because he felt terrible on the medications. Weak, dizzy, nauseous. His blood pressure was now 128 over 78. The numbers looked good, but James could barely walk. I did a comprehensive assessment. I checked his sitting and standing blood pressure. Sitting, 128 over 78. Standing, 98 over 62. Severe orthostatic hypotension. I assessed his frailty. He was frail. He moved slowly. He was weak. He'd already fallen once in the past month. I looked at his medical history. Diabetes, prior stroke, age 84, frail orthostatic hypotension, all risk factors for harm from aggressive blood pressure lowering. James, I said, I'm going to reduce your medication. I'm going to let your blood pressure come up. His daughter, who was with him, looked alarmed. But the doctor said 156 over 88 is dangerous. He said Dad could have another stroke. Here's the reality, I explained. At 84, with James's medical conditions, his risk of falling and suffering a catastrophic injury is higher than his risk of stroke from blood pressure of 150. The guidelines say we should lower his pressure. But the guidelines weren't written for someone like James. They were written for healthier, younger people. We reduced James's medications. His blood pressure came up to 148 over 84. His orthostatic hypotension improved. Standing pressure was now 128 over 74. Much better. James felt better. He had more energy. The dizziness resolved. He stopped falling. 3 years later, James is still alive. Still living in assisted living. Still independent with his daily activities. No falls, no stroke, no heart attack. Because we treated James as an individual, not as a number. This is personalized medicine. This is what geriatric cardiology should look like. And this is what I want for you. Now let me give you the actual numbers, the targets you should be discussing with your doctor. But remember, these are guidelines, not rules. Your individual target should be based on your specific situation, your age, your frailty, your other medical conditions, your medications, your history of falls. All of this matters. For healthy, active adults aged 65 to 74, a reasonable blood pressure target is systolic 130 to 140 and diastolic 70 to 85. At this age, if you're healthy, you can tolerate slightly lower pressures. But watch for symptoms. Watch for dizziness, fatigue, cognitive changes. And always check standing blood pressure to make sure you don't have orthostatic hypotension. For adults aged 75 to 84 who are relatively healthy and active, a reasonable target is systolic 135 to 145 and diastolic 70 to 85. As you get older, your baroreceptor reflexes slow down more. Your arteries get stiffer. You need slightly higher pressure to maintain adequate organ perfusion. For adults over 85, or for anyone who is frail regardless of age, a reasonable target is systolic 140 to 150 and diastolic 70 to 85. At this age, with this level of frailty, preventing falls is more important than hitting a specific number. Quality of life is more important than theoretical cardiovascular risk. For older adults with diabetes, prior heart attack, or prior stroke, targets may need to be slightly different, usually aiming for systolic 130 to 140. These conditions do increase cardiovascular risk, and modest blood pressure control helps, but aggressive lowering, pushing below 120, is still dangerous. The key is balance. You want blood pressure low enough to protect your heart and brain from the long-term effects of hypertension, but high enough to maintain adequate blood flow, prevent dizziness, prevent falls, and preserve your independence. And here's the most important number of all, your standing blood pressure. This is the number your doctor probably isn't checking. This is the number that predicts falls. Here's how to check for orthostatic hypotension. You need a home blood pressure monitor. Lie down for 5 minutes, check your blood pressure, write it down, then stand up, wait 30 seconds, check your blood pressure again while standing, write it down. If your systolic pressure drops by more than 20 points, or if your diastolic pressure drops by more than 10 points, you have orthostatic hypotension. This means your blood pressure medications might be too strong. This means you're at risk for falls. For example, if your blood pressure lying down is 132 over 78 and standing it's 108 over 66, that's a 24-point systolic drop. That's dangerous. Even though 132 over 78 seems like a good number, if it drops to 108 when you stand, you're not safe. Let me tell you about Carol, because Carol's story shows why this standing blood pressure check is so critical. Carol was 76. Her doctor had her on 3 blood pressure medications. Her sitting pressure was 124 over 76. Perfect, according to guidelines. But Carol complained of dizziness every time she stood up. Her doctor told her it was just age-related and to stand up more slowly. Carol's daughter insisted she come see me. I checked her standing blood pressure. Sitting, 124 over 76. Standing, 92 over 56. A 32-point systolic drop. Extremely dangerous. I reduced Carol's medications immediately. Her sitting pressure came up to 138 over 80. Her standing pressure was 122 over 72. Only a 16-point drop. Much safer. The dizziness resolved. Carol felt secure walking again. We prevented what could have been a catastrophic fall. This is why you need to check standing blood pressure. This is why the sitting number alone isn't enough. Now comment checking standing if you're going to start checking your standing blood pressure. Comment if you've never had your doctor check this. I want to see how many people aren't being properly evaluated. Let me address the question I know you're asking. What about the long-term risks? What about heart disease and stroke? Won't higher blood pressure increase my risk? Here's the truth. Yes, chronically elevated blood pressure does increase cardiovascular risk. If you're 65 and your blood pressure is 180 over 100, you need treatment. That's too high. But the relationship between blood pressure and risk is not linear in older adults. It's U-shaped. Let me tell you about George. Because George's story shows what happens when we focus on the number instead of the person. The aggressive blood pressure lowering had almost killed him. And for what? To hit a target number that wasn't appropriate for his age and medical condition. This is what happens when we treat numbers instead of people. This is what happens when we don't individualize care. Instead, say this. I've been reading about blood pressure targets in older adults, and I found some recent research showing that targets might be different for people my age. Can we discuss what the right target is for me specifically, considering my age, my other medical conditions, and my risk of falls? Bring your home blood pressure log. Show your doctor your sitting and standing numbers. If you have orthostatic hypotension, that's objective data. That's evidence that your medications might be too strong. Ask your doctor, what are the benefits of lowering my blood pressure further? What are the risks? How do we balance cardiovascular protection with fall prevention and quality of life? Most doctors, when presented with this information in a respectful way, will listen. They'll consider individualizing your target. Some won't. Some are so locked into guidelines that they can't think outside the protocol. If your doctor absolutely refuses to consider a higher target, if they insist on pushing your pressure to 120 even though you're experiencing symptoms, consider getting a second opinion. Your health is too important to compromise. Your independence is too valuable to risk. Let me share one more story, Helen's story, because Helen's story has the ending I want for all of you. Helen was 77. Her blood pressure was 152/88. She felt great. She was active, sharp, independent. Her doctor wanted to add blood pressure medication. Helen asked why. Your pressure is too high, the doctor said. We need to get it under 130. Helen asked, what happens if we don't? What's my actual risk? The doctor calculated her 10-year cardiovascular risk. With blood pressure of 152/88, her risk of heart attack or stroke in the next 10 years was 18%. If they lowered her pressure to 130, the risk would drop to 14%, a 4% absolute risk reduction. So, Helen said, there's an 82% chance I won't have a heart attack or stroke anyway, and lowering my blood pressure would increase that to 86%? That's correct, the doctor said. What are the risks of the medication? The doctor explained, dizziness, fatigue, orthostatic hypotension, falls, electrolyte abnormalities, kidney problems. Helen thought about it. She was 77. She felt great. A 4% risk reduction didn't seem worth the potential side effects. She declined the medication. She agreed to monitor her blood pressure at home, to have regular checkups, and to start medication if her pressure went above 160 or if she developed symptoms. 5 years later, Helen is 82. Her blood pressure is still around 150/85. She's never been on medication. She's never had a heart attack. She's never had a stroke. She's never fallen. She's still independent, still active, still thriving. Helen made an informed decision. She weighed the benefits and risks. She chose quality of life. And it worked out. This is patient empowerment. This is shared decision-making. This is how healthcare should be. Now, let me give you the complete protocol, the exact steps to take to make sure your blood pressure management is appropriate for your age and situation. Step 1, get a home blood pressure monitor, a good quality automatic upper arm monitor, not a wrist monitor. Those are less accurate. Get one that's validated. Check the American Heart Association's list of validated monitors. Step 2, check your blood pressure at home twice daily, once in the morning before breakfast and medications, once in the evening before dinner, always sitting at the same times each day. Keep a log. Step 3, check your standing blood pressure once a week. Lie down for 5 minutes, check pressure, then stand and check again after 30 seconds. Record both numbers. Look for drops greater than 20 systolic or 10 diastolic. Step 4, bring your log to your doctor. Show them the data. Discuss what the appropriate target is for you based on your age, your medical history, your frailty status, and whether you have orthostatic hypotension. Step 5. If you and your doctor decide to adjust medications, do it slowly. Change one thing at a time. Monitor closely for symptoms and for changes in sitting and standing pressures. Before we finish, I want to address one more critical point. What about people who've been on blood pressure medications for years? Can you stop them? Can you reduce them? Sometimes? Yes. There's a study called the Optimize trial that looked at older adults who were on multiple blood pressure medications. They gradually reduced medications in some patients while monitoring closely. Many were able to reduce or stop medications without adverse effects. Their quality of life improved. They felt better. And their blood pressure, while higher than before, was still in a safe range. But this must be done carefully, under medical supervision. Never stop blood pressure medication suddenly on your own. Never make changes without consulting your doctor. Sudden changes can be dangerous, but a careful, gradual reduction with close monitoring can sometimes be the right choice. Let me tell you about Paul. Last story, I promise. But this one matters. Paul was 85. He was on 5 blood pressure medications. 5. His sitting pressure was 112/68. His standing pressure was 84/52. He could barely walk. He was dizzy constantly. He'd fallen 3 times in 6 months. His family brought him to me. They were desperate. They thought he had Parkinson's disease or a neurological disorder. I looked at his medications. 5 blood pressure drugs. His blood pressure was being crushed. You deserve to live your best life at any age. You deserve to be treated as an individual, not as a number. You deserve a doctor who listens, who considers your unique situation, who balances risk and benefit. If this video has given you information that could change your life, I need you to do 3 things. First, subscribe to this channel. Click that button right now. I'm going to keep making videos like this. Videos that tell you the truth about health issues affecting older adults. Truth that your doctor might not know or might not have time to explain. Second, share this video. Send it to your family members, your friends, anyone over 65 who's on blood pressure medication. This information could prevent a fall. It could prevent cognitive decline. It could save a life. I also want to invite you to join my newsletter. The link is in the description below. Every week, I send out detailed health information specifically for seniors, topics your doctor doesn't have time to discuss, research findings that haven't made it into practice yet, practical advice you can use immediately. It's free and it's packed with information that could change your health. So, if you're 70, 75, 80, and your blood pressure is 138/82, and you feel good, don't panic. That might be exactly where you need to be. Check your standing pressure. If it's stable, if you're not dizzy, if you're not falling, if you're living your life fully, you might be perfect just as you are. Talk to your doctor, have an informed conversation. Use the information from this video as a starting point. And remember, you're not just a number, you're a person with a life to live, with things you want to do, with people you want to be there for. Your blood pressure management should support that life, not diminish it. Thank you for watching all the way through. Thank you for trusting me with your time. I'll see you in the next video, where we'll continue taking control of your health together. Until then, take care of yourself, advocate for yourself, and remember, the best blood pressure for you is the one that lets you live your fullest life at any age.